So we are getting to the end of the guidance update. And before I move on to the next one, a question for you guys. What is this abdominal film showing? What is this abdominal film showing, guys? What is the diagnosis? Yeah, small bowel obstruction. This is small bowel obstruction. Absolutely. Abigail and Rachel, thank you very much. So we can see the various different rings of the small bowel here, but this actual bowel is huge, right? We can see how huge this bowel is. Massive, massive bowel, isn't it? And this is dilatation, small bowel dilatation. And bowel obstruction is one of those things that will send you into a little bit of a shock, whether in primary care or secondary care, and is a very serious disease. Now, finding out the cause of it may not necessarily be your job, but identifying whether there is bowel obstruction or not is your job. Now, these patients, the bowel's not working, nothing is moving. So therefore, they will have abdominal distension, they will have vomiting, they will have nausea, and they will have tinkling bowel sounds, as opposed to the grumbling of the bowels that I'm sure my stomach and your stomach are all doing at the moment as we're nearing 1 o'clock. These patients require an abdominal x-ray in the first instance, but almost always have a CT scan acutely. And of course, the scan is there to try and find out what might be causing the bowel obstruction, and therefore allowing us to, surgeons to basically plan for surgery. It also tells us whether the obstruction is down to an ileus, whereby there might be a physiological cause, maybe electrolyte deficiencies like potassium causing the lack of movement of the bowel, or whether there's something physical. If it's a small bowel obstruction, these patients require an NG tube and intravenous IV fluids. And of course, if it's an electrolyte cause, then that needs solving, but otherwise they require surgery. The next one is appendicitis, which is a periumbilical pain moving to the right iliac fossa using kind of McBurney's point. These patients are tachycardic, they have a fever, they guard, they might have constipation and diarrhea. And of course, if you're in primary care, these patients require urgent referral, ideally to SAU, but unfortunately, most of them end up in A&E. Diagnosis is clinical, but you can also do some bloods. If the CRP is raised, that might actually give you some additional support for your diagnosis. Some of these patients may require a CT scan, especially if there's diagnostic uncertainty, but ultimately they require a surgical team to explore the appendix and take it out, especially if it's an acute appendicitis. The jury's out about as to whether they need antibiotics or not, because once an appendix is inflamed and infected, antibiotics do very little because it just ultimately needs removal. But some trusts do recommend giving some cefotaxime, metronidazole, or other antibiotics, depending on your local guidance for these patients. So the next case, before we get to the end, is a 49-year-old male patient presents to your GP clinic after noticing an unusual bowel movement, I should say. He's well in himself, although he has gastric reflux and he takes lansoprazole. These are your observations. What kind of questions would you ask this patient? Any blood in the stools? Yep, that's one question. Any pain? Pain. Appetite change. Consistency and frequency. Weight loss. Yeah, good. These are really good questions. Pain, consistency, frequency, weight loss. Yeah, absolutely. Whether there's any vomiting with blood, as an example, whether it's worse at day or night, absolutely. Let's just say this all started today. You may want to ask about whether there's been any alcohol binges, whether they've taken any medication, for example, like NSAIDs, because you ask them what their stool looks like and they say, oh, doctor, I've actually brought it in. Some patients do. And you see this. What are you now concerned about? Upper gastric. Yeah, upper GI bleed. Absolutely. GI bleed is what you're concerned about. Yeah, secondary to an ulcer, potentially, Carol. GI bleed, no doubt. So these patients may have melena, hematemesis, or even low energy, and they require a rectal examination to check if there's any melena there. They may have coffee ground vomit, and of course, FBCs, and they may require an FBC and Usinese. Now, ultimately, these patients require risk stratification, and there are a few tools that we can use for this, like the Glasgow-Blatchford bleeding score. But in emergency cases, these patients require acute stabilization, blood transfusion, and even fluids. And the definitive treatment for these patients is that they need to be treated with an IV PPI, IV antibiotics, and of course need endoscopy urgently to explore what might be the cause of bleeding. Endoscopies are brilliant because they are not only investigative, but they're also therapeutic. So they will also help to solve the problem if they can, to try and fix the ulcer. And this is the Glasgow-Blatchford bleeding score. Some gynae emergencies. I've got three left. So the first is an ectopic pregnancy. These patients, the reason why we mention these is that yes, they're gynae, but they of course come to general practice or A&E or A&E first and foremost, or urgent care settings. So therefore, knowing what an ectopic pregnancy is really important. Abdominal pain and shoulder pain with unusual discharge. These patients will give you a history of the fact that they've missed their periods. They may not necessarily be aware that they're pregnant, but you have to do a pregnancy test. And if that's positive, then, you've almost got your diagnosis clinically. The key is that this patient might have a perforated ectopic pregnancy, in which case they may be very, very tender in their right or left iliac fossa. They may be guarding with hemodynamic instability. Unfortunately, the fetus cannot be saved in an ectopic pregnancy, and the treatment is multifold. It could be expectant. In other words, you know, um, it could be a watch and wait, because sometimes the actual tubes from the ectopic pregnancy, it's called a tubal expulsion, where the ectopic pregnancy is kind of is almost thrown out by the womb naturally. Or these patients may require medical treatment, such as methotrexate, or in the case of a perforated ectopic pregnancy, they will require urgent surgery to remove the pregnancy, usually with the affected fallopian tube inside. Ultimately, our job is to refer these patients on immediately. Another condition which is being recognized more and more as an emergency and can produce emergency problems, well, life-threatening problems, is a miscarriage. Miscarriages are part and parcel of the way the reproductive system operates. Unfortunately, they are unfortunate when they happen, and managing the patient's expectations and emotions is very, very important. But as a clinician, you want to make sure that they're safe and they're well. Serious miscarriages can lead to serious abdominal pain and PV bleeding and hemodynamic instability. Of course, they'll have a positive pregnancy test, but you will have to be able to do a PV examination. This is specifically a message to the blokes on the course today. Please be comfortable doing a speculum. If you don't know how to do a speculum, learn how to do a speculum. Be confident in doing a speculum, because some of these patients may have cervical shock because the products of conception may be within the cervical os, and the only way to deal with their problem is to remove it, and you may not have somebody around you to help you do so. So it's about taking what we call sponged forceps and gauze to try and take out any clots, any bleeding, any products of conception, to reduce the pain that the patient's going through and also improve their hemodynamic stability. So that is miscarriage. And last but not least, previous experiences ultimately do define or help to define what you do and what your practice is. I've seen way too many of these to not include them in our course today, which is cholangitis or gallbladder-related emergencies, but specifically cholangitis. Cholangitis occurs when a gallstone is stuck within the common bile duct, resulting in right upper quadrant pain, jaundice, and fever. These patients require LFTs, which are completely off the Richter scale, especially with ALP, which is high, and bilirubin, which might be high. And because these patients have an infected obstructive system, they require high doses of antibiotics, immediate referral to general surgery, and ultimately for what we call an ERCP, which is an endoscope, but for gallstones. So not only does it help to find the gallstone, but you can also use it to either blast it with ultrasound or even pick it up and collect it and take it out, and therefore solve the problem. And this is just a small table of what you do for the various different gallstone presentations. So for straightforward gallstones, it's an ultrasound scan. For cholecystitis, it's normally an ultrasound scan as well. And of course, for cholelithiasis, which is kind of cholangitis or stone in the CBD, it requires an ERCP or an MRCP to definitively remove it.